Think of yourself as the consultant getting this referral. Here it is. A 45-year-old woman presents with a recurrent, mildly painful erythematous plaque on her forearm. Now, it looks a lot like cellulitis, but here's the kicker, Lid. It's not getting better with antibiotics. So they do a biopsy. The path report comes back describing flame figures. It says these are characterized by eosinophilic granules coating collagen bundles within a dense dermal infiltrate. So the question is, what is the most likely diagnosis? And your choices are A. Bullous pemphigoid, B. arthropod bite reaction, C. Wells syndrome, D. eosinophilic fasciitis, or E. chronic urticaria.
Okay, that's a beautifully constructed question. Classic exam style. You've got some misleading clinical signs up front.
The cellulitis mimicry.
Exactly. And then you have this one really specific histopathology finding that's meant to be the clincher. As the clinician, you got to weigh these carefully. Let's pull out the key indicators. First, the clinical stuff. This red, kind of swollen plaque that looks like cellulitis, or inflammation. But like you said, it's recurrent and, crucially, doesn't respond to antibiotics.
Right. That immediately makes you think, well, maybe not bacterial.
Precisely. It strongly suggests this isn't your run-of-the-mill cellulitis. You start thinking about other inflammatory things, reactive processes maybe.
Okay, but just the antibiotic failure alone. I mean, couldn't it be a resistant bug? Or something else that looks like cellulitis?
Yeah.
How solid is that first clue?
That's a fair point. Resistant bacteria are out there. And yeah, other things, vasculitis maybe, can mimic infection. So clue 1 mainly tells us what it probably isn't. It's a great mimic we're dealing with. But the recurrence pattern and the fact it stays sort of localized does point more towards some kind of, cyclical, non-infectious inflammation. Still, you wouldn't hang your hat on just that. You need the pathology.
Which brings us to clue 2.
Which is the absolute game changer. The flame figures, eosinophilic granules coating collagen. When you see that phrase in a path report, well, that's pretty much diagnostic gold.
The phognomonic, right?
You got it. It narrows the possibilities right down. It basically points to one specific entity.
Okay, so if flame figures is the key, linking that to the choices, the answer has to be C. Wells syndrome.
Correct. Based on that definitive histopathology clue provided in the sources, it's Wells syndrome.
All right, so let's unpack Wells syndrome, or eosinophilic cellulitis as it's also known. Why does this condition produce those specific flame figures? Let's start right there with the histology.
Yeah, the flame figure is really the visual hallmark of what's going on immunologically. It defines Wells. And it's important to understand this isn't primarily a blood vessel issue, which you see in lots of skin conditions.
Okay.
This is an actual change to the collagen fibers themselves in the dermis.
So the immune system is attacking the skin structure.
It's more like the body is overreacting really aggressively to something. Often we don't even know the trigger, but it sends in this huge wave of eosinophils, a type of white blood cell.
Right.
And when these eosinophils get into the dermis, they degranulate, they basically dump their contents. And those contents include some pretty potent cytotoxic proteins.
Toxic stuff.
Yeah, and the key player here is something called major basic protein, or MBP. Think of it as this really sticky, damaging goo. When this MBP gets dumped onto the collagen bundles, it coats them, it sort of obscures them, changes how they look under the microscope, gives them that characteristic eosinophilic, kind of refractile, flamey appearance. That's your flame figure. It's the footprint of that eosinophil degranulation.
Wow, so the cellulitis look is just the surface inflammation, but the real action, the signature damage, is deeper with this MBP coating the collagen.
Exactly. That's what makes it Wells syndrome.
Now, the case mentioned this plaque, but Wells lesions can actually change over time, right? The sources talk about stages.
Yeah, absolutely. That initial phase, the acute one, that's the bright, red, hot, cellulitis-like plaque that fools everyone, but then it often evolves.
Into what?
It can move into a sort of subacute, more granulomatous phase. The intense redness might fade a bit and the lesion feels firmer, maybe even a bit nodular. That's the body trying to wall off the inflammation. And then, as it resolves, it can sometimes leave behind this kind of greenish-blue or bruise-like discoloration. That's thought to be from the breakdown products of all those eosinophils and the MBP being cleared out by macrophages.
Interesting. So if we zoom out, the big picture is this intense eosinophil-driven inflammation. But why does it happen? What sets it off?
That's the million-dollar question. Often, we just don't find a specific cause. It's labeled idiopathic. but it's clear the immune system is hyperreactive.
But there are known triggers sometimes.
Yes, definitely. The sources list several possibilities. Infections can do it. Parasites seem to be a classic association, but viruses too. Certain medications are implicated.
Okay.
Arthropod bites, insect bites, or stings are actually quite well-known triggers. And importantly, though it's rare, sometimes wells can be a reaction to an underlying malignancy, so it can be a signpost for something serious hiding underneath.
That makes getting the diagnosis right even more critical. Okay, let's circle back to those other options in the MCQ. Why aren't they the answer? This helps solidify why Wells is correct. Let's go through the differentials.
Good idea. Critical thinking here. Let's start with A. Bullous pemphigoid.
Also involves eosinophils, right?
It does, heavily. But BP is fundamentally different. It's an autoimmune blistering disease. The antibodies attack the junction between the epidermis and dermis.
So, different mechanism.
Totally different. Histologically, yes, you see eosinophils, often lots of them, and a subepidermal blister. But critically, no flame figures. And the diagnostic test is immunofluorescence, looking for that linear IgG and C3 at the basement membrane zone, not what our case described.
Okay, makes sense. What about B, arthropod bite reaction? You said bites can trigger Wells.
Oh,
So this sounds tricky.
this is probably the trickiest one on the list, yeah, because a really intense reaction to a bite can have a ton of eosinophils. And maybe, just maybe, you might see some localized areas that kind of look like flame figures.
So how do you tell them apart?
It often comes down to the overall picture. In Wells, the flame figures are usually widespread and dense within the lesion, reflecting this massive, almost systemic overreaction. Clinically, Wells tends to be these larger recurrent plaques, often without a clear history of a specific recent bite causing that lesion.
Whereas a bite or reaction.
Might be more localized, maybe multiple itchy spots corresponding to bites. It's more of a direct, albeit sometimes exaggerated, response to the bite itself rather than the sort of self-perpetuating syndrome that Wells becomes. The recurrence and the solitary nature in the case lean towards Wells.
Got it. Okay, moving on to D, eosinophilic fasciitis. Sounds similar with the eosinophilic part.
Similar name, different zip code, anatomically speaking. Eosinophilic fasciitis, as the name implies, affects the fascia. That's the deep connective tissue over the muscles.
So much deeper than the dermis where flame figures are.
Exactly. Clinically, it's very different, too. You get this deep, woody hardness of the skin, sometimes a peau d'orange or orange peel texture. It can lead to joint stiffness, contractures. It feels tethered
That's
down.
on the biopsy.
Needs to be deep. Really deep, including that fascia, to show the inflammation and thickening there. And the key thing, flame figures are not a feature. The inflammation is in the wrong place and looks different.
All right. And lastly, E, chronic urticaria, hives.
Yeah, this one's pretty far off from the case description. Chronic hives, histologically, are very subtle. You might see some swelling dermal edema and a sparse scattering of inflammatory cells, maybe some eosinophils around blood vessels.
But nothing like the dense inflammation or flame figures.
Not even close. Urticaria lacks that dense, destructive infiltrate. The biopsy immediately rules it out. So yeah, once you have that path report with flame figures, the differentials just melt away.
Okay, so we've nailed the diagnosis. Wells syndrome, driven by that acasophil degranulation in MBP coating collagen, mimicking cellulitis but confirmed by biopsy. What's the typical course for patients? The prognosis.
Well, the sources are clear. It's typically recurrent. Patients have these episodes, these flare-ups, that eventually resolve on their own, but then they often come back.
Self-limited episodes, but chronic recurrence.
Exactly. It's generally considered benign. It's not going to kill you directly, but it can be really troublesome, uncomfortable, and frankly distressing for patients, sometimes going on for years.
And since it's inflammation, not infection, how do we treat it?
Right. Treatment is all about calming down that immune response, specifically those eosinophils.
Steroids.
Yep. First line is usually oral corticosteroids, something like prednisone. The dose might be around 0.5 to 1 milligram per kilogram per day, depending on severity.
Does it work well?
Oh yeah, usually very effective, often quite dramatic, rapid improvement. That quick response can even help confirm the diagnosis sometimes, but you can't keep someone on high-dose steroids forever.
Side effects. And the recurrence problem.
Precisely. So
Right.
if it keeps coming back, or if you're trying to get them off steroids, you need other options, steroid-sparing agents.
Like what? What do the sources mention?
Dapsone is a common one. It has anti-inflammatory effects, seems to dampen down eosinophil activity. Minocycline, an antibiotic, is sometimes used too, likely more for its anti-inflammatory properties than any antibacterial effect in this case.
Interesting.
Even things like antihistamines might help a bit with itching or milder symptoms, but probably won't stop a major flare. The goal is really long-term control, minimizing those flares while avoiding too much steroid exposure.
That makes sense. So a really fantastic case study here. I think the big takeaway for everyone listening is if you encounter what looks like cellulitis, especially if it's recurrent and not responding to antibiotics,
Think beyond infection.
exactly, push for that biopsy because seeing those flame figures, that eosinophilic coating on the collagen, is your diagnostic shortcut. It points straight to Wells syndrome.
Absolutely. And maybe one final thought to chew on. We talked about triggers, infections, bites, even malignancy sometimes setting this off. It makes you wonder, doesn't it? When you see this massive inflammation playing out so visibly in the skin,
Yeah.
is it always just a skin problem? Or is the Wells syndrome sometimes, the tip of the iceberg, a visible sign of some deeper systemic inflammatory process or reaction happening elsewhere that we perhaps need to look for even after the skin clears?